Good morning, everyone. Today is November 29th. It's towards the end of the month. And we needed to celebrate somehow what is recovery for patients with addictions or people with addictions rather, because believe it or not, September is recovery month. So we needed to do something with that. We couldn't forget about that special month. And for that, we're going to be talking about addictions today and how addictions affect families, affect the communities, but most importantly, what we can do to help those we love. So stay with us. If you know somebody who can use this information, call them up, tell them to jump on Zoom and watch us right now, and that way they can ask their questions live. And let me introduce myself first. I'm Sandra Arevalo. I'm the Director of Community Health and Wellness for Montefiore Nyack. And we also have with us three very special people. So Susan Mazzarella, Anderson Torres, and Yandira Melon. So I'm going to ask them to introduce themselves. Susan, do you want to start?
Yes, thank you for having me. I'm Susan Mazzarella. I'm the director with the Employee Assistance Program here at Montefiore Nyack, and we are an internal and external provider of EAP services in Rockland County with a few contracts in Orange County as well. I'm an LCSW and certified in EAP work.
Thank you. Anderson?
Hello, everyone. I'm Dr. Anderson Torres. I'm the president and CEO of RAIN, not-for-profit 58-year-old social service organization geared to helping those in the community. I am an LCSWR, so social work is my foundation from Hunter, Silverman School of Social Work at Hunter, and my doctorate is in behavioral psych, specializing in Alzheimer's and also trauma.
Yandira?
I'm Yandira Mellon. I'm also with the Montefiore Nyack Employee Assistance Program. I'm a licensed social worker and a certified employee assistance professional as well, and I work along with Susan.
Thank you very much. Okay, so let's get started. And I know that you put some slides together, Anderson, correct? So
Yeah.
you want to just start with that?
Sure. Let me share the screen. Let me attempt to take a stab at this technology. So thank you. And thank you, Ms. Arevalo, for this opportunity to speak before you and our guests. And the topic is looking at the emotional wellness and impact on addiction. And at the end, there'll be information regarding resources that anyone can call that's free for help. Think that, to frame the discussion, we start with identifying what addiction is. And it's defined as a chronic relapsing disorder characterized by compulsive drug seeking and use despite adverse consequences. It's a brain disorder because it involves functional changes to the brain and, in relation to reward, stress, self-regulation, self-control, and they may last a long time, even after the person has stopped taking drugs. And I know that there was a question in terms of if a person has stopped taking drugs, is there a danger for relapse? Once a person has an addiction, relapse is a reality in the life of that individual and becomes a reality for those around them as well. There are various types of addictions, and some people may identify with one or another or several. So not one is exclusive to each individual in each situation. So you have them listed here, and you might, hear a lot more of the alcohol. Then you have the prescription drug addiction. And here you might see that more with pain management as well. And you're going to hear along the discussion, I'm sure, comments related to the older adult and also the management of chronic pain management and what that might look like, the drug addiction, the heroin, and the opioid. There's always a risk, and you look at your earliest exposure to drugs, and you have babies that are also born to addicted mothers. And keeping in mind that anything that the mother ingests during that critical period of time, the baby is susceptible to that. So you also have babies that then would go through withdrawal upon birth. And that's very difficult to experience and watch, especially for the providers and for the family. I wanted to give you an image of the brain. On the left-hand side, you have someone who has not taken drugs, all right? And the second and third brain image picture gives you an example of how the brain develops and even responds even after the person has taken drugs. So you see the red on the first slide within the brain, that never really truly comes back in full force, even after the person stops taking drugs, which is reflected in the last or the third image on the right-hand side. So just to give you a snapshot of the development and the impact that brain is impacted by the use of drugs. Here we have the risk factors and the protective risk factors. The protective risk factors lowers your risk to some degree in becoming or addicted or proceeding with addiction to drugs. So you have someone that has, you know, a certain structure, certain relationships that may help the individual in his or her journey. When research is reviewed, it doesn't really highlight one particular risk because it's a combination of several things that would, you know, lead you into the addictive space. Okay, but a person, for example, with less supports in place, even as a child or adolescent, with lack of structure and supervision and certain aggressiveness, would have a higher incidence of a potential drug use or experimentation that may lead to later on addiction. And you know, why do people take drugs, right? You have the four top headers here: feel good, feel better, do better, and curious. So you look at, you know, what is the surrounding picture around the individual? What may the individual be looking to replace that will drive the drug? Even if the high may last 15 seconds or so, it's still a better state of feeling than something else that they may be experiencing. So, you know, you go into depth here, and these slides will be shared with those that are attending. I have shared them with Ms. Arevalo as well. These are the commonly used drugs, and you know what makes it a little challenging at times is certain drugs are also being seen in social gatherings. For example, alcohol, you know, tobacco. How many of us are using now vaping? You know, the legalization of certain drugs and so forth. So we take all that into consideration, but these are the most commonly used drugs. I've also added the source of information to most of the slides as well. So you have different types of treatment. I know my colleagues here are going to delve more into that. I, on my end, in practice, have seen more of the cognitive therapy. Some people have had to go into rehab or detox units and then come back to the behavioral therapy on the community outreach side. So first steps, right? You look at when we address the addiction, the detox, the counseling, right? The behavior therapy, the coordination of the aftercare, even when a person has gone into a detox unit or rehab program, is critical in order to support the recovery process that must take place, right? This, so the support groups, the medications, and the takeaways. This is just a little snapshot on the substance use among teens. And so what we're seeing is that alcohol has been reported well before the age of 15. But you look at typical heights in age range, and it goes between 15 and 17. And the pot or the marijuana use has gone even on before the age of 13 in terms of use. Hallucinogens have been reported also at the age of 12. Just the other day, I met somebody who had exposure to alcohol forced at the age of 9, a whole bottle of gin, as an example. And she also happened to have been a victim of a rape, but that was her introduction to alcohol, was at the age of 9. And it was with parental consent. So you hear these stories and situations out there. So it's important to understand the trauma that may go on in a person's life that may have exposed him or her to early use of drugs that I mentioned. Substance Abuse and Mental Health Services Administration, SAMHSA, many reported as such. There's a national helpline in English and in Spanish, and this is the number that I was referring to early on in the presentation that one can call, and it's a 24/7 treatment referral hotline. And then I've also provided a link for additional information and resources on the subject matter. So I just wanted to give a brief overview of the subject at hand, and I'm sure that we'll interact and dialogue with each other to help those that are watching.
Most definitely, that was a great introduction, and you already answered a lot of the questions that we had on your introduction, so that's really great. And we have one more person in our panel. So Aaron, we have already introduced ourselves and started a little bit. So do you want to introduce yourself?
Sure. I apologize for being late. I was taking care of a patient. I'm Aaron Solon. I'm the behavioral health clinical pharmacy specialist here at NIAC. I guess a little bit about me briefly. I went to pharmacy school at Ohio Northern University. I graduated in 2017. I completed a research fellowship in pharmacist roles in reducing the sequelae or consequences of addiction, particularly opioid use disorder, at East Tennessee State University, where I received a master's in public health. And then I went on to complete a specialty residency in psychiatry at Rutgers, and I'm board certified in psychiatric pharmacy. So sorry I'm late, but very happy to be here.
No, you're always welcome, late, early, whenever it is, you're always welcome. Thank you so much for being here. So, Sue, let's start with you. Dr. Torres just made a very comprehensive list of a lot of addictions, and also mentioned risk factors for addictions. And he even gave some examples on how addictions start. But in your practice, what have you seen, like how can addictions start? And as family, like, for example, I was looking at the stats that Dr. Torres was showing, and I was astonished because my daughter just graduated high school, and I'm going like, oh my God, is changing the stats or not, So as a family, what do we do to prevent this from happening?
Well, I mean, I think there's a number of risk factors, including genetic. There's a strong genetic component, as well as just various biopsychosocial pieces of addiction. And I know that people are always saying, well, what comes first? The substance use disorder or misuse, and then a psychiatric or a mental health issue, or is there mental health issues pre-exist substance abuse? I think that's very hard to say. I just go by very simplistically. People generally use drugs to feel things or not feel things.
Yeah.
So if they want to feel emotions or feelings that they're not able to, maybe that's happiness, maybe that's, letting go of loneliness, or not wanting to experience the trauma. So they're going to not feel things and self-medicate, or if they want to be able to feel other, certainly pleasure is one of them, but it's also sometimes a way to feel if people aren't able to feel good feelings. And drugs and alcohol generally in the beginning do that to people. They help you to feel good. Until they start kind of working in reverse, and then people often at that time have a very difficult, difficulty getting off the drugs or stopping the use. So I think it really just, certainly you want to be able to pay attention to your children and be able to discuss with them well before high school. You don't want to wait for them to get into high school. Most kids are getting, education around drugs and alcohol at very young ages, but you really want to add to what they're getting from, the school system. You want to be able to model in your own house, use, of alcohol, certainly the dangers of, illicit drug use. But you want to be able to have those conversations early on rather than wait till your kids are, in middle school even or high school. But there's so many predisposing factors. And I certainly, Anderson mentioned one, which is histories of trauma often can greatly impact someone's predisposition to become substance abusing.
Thank you. Yandira, at what age do people start getting addictions? Is it a specific age? It could happen anytime because, I cannot imagine a 4 or a 5-year-old with an addiction, right? But
Well,
could addictions start that early?
Well, as Dr. Torres pointed out, they are unfortunately babies, okay, that are born with substances, because of the mother's use. But there is, of course, a medical procedure and medical treatment to wean that infant, that newborn out. Is there an exact age? That's out of my realm. However, I have known 9-year-olds that have been addicted to alcohol as well as other kinds of drugs. There's a big debate also in terms of what is marijuana substance use, what is acceptable and when does it.
It's a sound issue.
Oh, it's my microphone here. I'm sorry. So it's something to be on the lookout for. There are certain types of behaviors that we have to look for in terms of tolerance, in terms of behavioral issues affecting the family as well, of course, as the child. So back to your question, there isn't a particular magic number, but it can happen at any age. Let's just put it this way.
Okay.
And if you allow me, Sandra, for a moment, just to elaborate a moment on Yandira's comment, you sometimes hear children from the age of 7 or 8, oh, the magic marker smells good. As an example, what we are attracted to, what glue as well. So, you have children at earlier ages. We're not saying that just because you smell a magic marker or glue that you're going to be addicted to drugs or anything like that. But you just, even in the behavior and in the language and what resonates and what the brain and body responds to is important to pick up and observe.
Yeah, that's interesting. How do we distinguish between, I guess, a trial or a habit or an addiction? How do we do that, Dr. Torres?
Well, you look at patterns of behavior, and it's interesting you said that, because I would say you already know when someone's behavior is inappropriate or se pasa de la línea. I mean, it's not in form, right? It's not fitting within the normal structure. You have individuals, for example, that begin to manifest difficulties even in their responsibilities at the job, tardiness, lateness, difficulties concentrating, difficulties sleeping, appetite changes. So it's important to take a multi-systemic look at impact and see what falls within again, a normal range of a response. Say, for example, someone just had a death in the family and they go through a bereavement process. So you will have certain behavioral symptoms that will be expected. But as it relates to just a negative impact and delay where people around you start noticing it and they're saying to you, there seems to be a concern, that's when we begin to look at, this is not the norm in this context. And I'm sure Sue and others will chime in.
I think that, there really is a progression as far as, the disease model. The progression often, you look at, increases in tolerance, cravings, people that, people may have towards various drugs, or, certainly we're talking about drugs and including alcohol, but people can really, if you will, develop, addictions towards, a number of different things, right? Whether it be spending or sex or, any gambling, certainly we know that. And those are, if you will, gambling is part of our diagnostic psychiatric manual now, finally. But there really is a progression. And I always really think you have to look at the people's inability to really control with any degree of certainty when they use, how much they're going to use, or what the consequences or outcome of use is going to be, so that loss of control to a certain degree, or having any clear sense of what's going to happen or how much I'm going to use, whatever the substance may be, is one of the indicators that people are moving beyond, if you will, social use or even abuse towards more dependency, whether that be dependency with or without physical dependence. It doesn't necessarily really matter, because people can be dependent without being physically dependent on their substance. But there really is a progression. It really, you can very clearly see it when you're assessing someone for substance use disorder.
Mhm. Now, is addiction something that you need to be doing every day? Let me explain myself. We have what people call social drinkers, right? Like you go to a party and you drink, you get drunk, whatever it is, but you don't do it until the next party. It's not that you're drinking every day. Or same with some drugs. I know that there are people that are like, oh no, I only use drugs, with friends or something like that. So could we call that addiction as well, or does it have to be a daily routine in order to be called an addiction?
Addiction can come in many different packages. So it's interesting you say that, because there are a couple of people that I know. One is an 86-year-old lady who just had knee surgery, and she had been used to drinking beer every day. When her surgery came and she needed to be hospitalized, she had a conniption because the doctor says you cannot have your beer in the hospital during this time. And she started having withdrawals around that, which caused for an early discharge back into the community. Yet she doesn't feel that she has a problem.
Mhm.
The rest of her family does. Look what it did. It had an interruption and an impact on her recovery from a surgery. Then you have people that, are perfectly fine during the week, Monday through Friday, come the weekend, and they just, binge drink from a certain time to a certain time, yet they don't have a problem because they say it's not interrupting my work week. I'm still productive. So, I think that it's very individualized in how people perceive their addiction and their pattern.
Mhm. And
I'm sorry, Sandra, I just
Oh,
like
go
to
ahead.
speak to what Dr. Torres said about alcohol withdrawal in a hospital setting. I can't remember the exact figure, but a large percentage of patients will need treatment for alcohol withdrawal on a hospitalization that is not related to alcohol use. So that's something that I think is, when I first read it, it was surprising, but for similar situations, someone who is having several drinks throughout the week for maybe for years, and all of a sudden they're in a scenario where that's not available and you could potentially run into issues. So most clinicians will screen for alcohol use regardless of what the person is being brought to the hospital for.
Now, I'm going to make a very dumb question, but I think that it's important because it's going to help people understand, right? Like, I mean, you just said something very interesting. If you're used to having a few drinks a week with your dinner or whatever, you're going to come to the hospital. And of course, the last thing that they're going to give you is wine with meals. But let's say I'm used to arepa, right? Like, and I'm not gonna get arepa in the restaurant. So does that mean that I'm addicted to arepa? I know it's dumb. The question is dumb, but you know, I'm trying to put things into context.
My response, and all, of course, anyone can piggyback off of it, is, you know, addiction is very much a behavioral, we're looking at the behaviors. Are you going out of your way to find an arepa? Are you, you know, are you spending majority of your day trying to afford this, trying to procure it? And then if you don't have this, are you experiencing a withdrawal syndrome? And I think in most folks who are maybe social drinkers, where they're whatever they're using is in small quantities and infrequently, if that behavioral drive is not there, then there's not as much of a concern or a label of addiction. But for others that are, you know, counting their pennies until they can purchase the next product, whatever it may be, those folks may be more at risk in a hospital setting.
Well, thank you. I think that now you made it very clear, you know, between, let's say, how we call it, like an antojo, how you say an antojo? A craving, thank you, a craving and an addiction, right? I might be craving something, but it doesn't make me as crazy. Okay, so.
Oh, is that after this presentation, I better be getting an arepa.
For those of you who don't know arepas, I'm from Colombia. We eat arepas. It's like a tortilla, but a little thicker. It's made of corn. I'm sorry for those of you who might not be familiar with arepa, but you know, we eat it every day, or almost. So, okay. So now I'm completely clear in the difference between addiction and non-addiction. So, getting somebody to accept that they have an addiction can be something very difficult. And we might identify that there is an addiction problem, but they don't. We are discussing this. So as family or friends, how can we start that conversation? What do we need to say? Because, you know, most people, when we say, we think you have a problem, you know, they deny it. They don't want to hear it. They get angry. A lot of times. So how do we start that conversation?
Yandira, do you want to try the speaker again here? Or?
No, I'm gonna try.
Okay.
That sounds good now.
Okay. Starting off with the behavior. Okay. And the recent behavior. Don't go, well, I'm concerned about you because, you know, last Christmas you did this and this, and it's not Christmas. So you have to stay with the current situation, be very concrete, and how that behavior has affected you or has affected someone else, and that you're concerned. So I always tell my clients and even loved ones, start with the concrete. You know, what happened, the who, the what, the where. Because the other person can't argue with you about that because it happened. All right. So that we start with that in terms of then turn it in terms of how it has affected you and how you want to be there for that individual. You have to start where they are at that particular moment. Getting back to what Aaron mentioned, if there are consequences, well, you know, you're on probation because you missed a couple of work deadlines too, and that affects the family if we're talking about a significant other addressing. So it's, again, putting the here and the now and its effect on you, and that you're together with that individual in getting help. So that number that Dr. Torres brought up, you have it and you say, okay, let's start. So that's a good start. Being from an EAP, okay, if you are in a location, a workplace location that has an EAP, then definitely taking it to that level of making an appointment, talking to an EAP counselor to get you prepared to have that dialogue, or to also bring in your loved ones into that dialogue. Because again, it's a disease, illness with behavioral issues. So you have a lot of what I call levels with this situation. So you really should encompass as many levels in providing the help and support afterwards as well.
Mhm.
Yeah,
Sue?
I just want to add quickly, I mean, I think starting from a place of genuine care and concern and being as concrete as you can be, I think you want to be able to expect that there's certain defensive structures that anyone who has a substance misuse disorder is going to have, and, denial and rationalizing. And there are times when, your loved one might not, when you're wanting to address this out of concern and a genuine place, and being very concrete and very factual, where they may see it very, very differently.
Mhm.
And part of it might be that because they were under the influence, and their recollection of those events is very, very different. And part of it is going to be the defensive structures that are part of the symptomology and the progression of the illness. So it's not that your loved one is, if you will, a kind of just being maybe oppositional, or playing dumb, or that they've kind of turned into this immoral, or kind of corrupt place. That it really is that they're probably even farther along into the use disorder than you might have really even thought. So, you want to be able to take that in mind, and especially if there is pushback, use other resources you have. If you have an EAP program, if you have, other counselors, other individuals, there's often support through Al-Anon, which is for family members and loved ones, that you can be able to bring to your aid to help you to be able to have those discussions and recognize what you can do for that person, and what you're really going to be able to need to let them do for themselves. That's one of the hardest pieces for families, is the acceptance and recognition to some degree, or to a greater degree, that they are not going to be able to resolve this issue for the individual with the use disorder.
Mhm.
They're not going to be able to fix it.
Dr. Torres, there are people who are in such denial, right? That Sue is just saying you can bring someone else or a team or experts into the equation to help with treatment. But there are people who don't want to even hear about treatment. They don't want to know about therapy. They don't want to know about anything, right? And they definitely have a problem. So what do we do with people like that?
And thank you. I wanted to go back for a moment on something Susan mentioned. But I'm standing strong on that you need to be firm and caring. There needs to be limits, and you have to be prepared to place those limits as well. But anybody that's offering any type of support or addressing the individual with the issue at hand, my recommendation is that they become versed in the subject matter in terms of information regarding, the drug that's being used, its impact, because information is power as well. We've had several families or several situations that we can all relate to in terms of, sitting down with the individual and saying, this is what we've noticed, this is the impact that it has had on us, validating the experience. And what I want to do is that I also want to go and touch a little bit about on the subject of adolescence. So some people feel that they have to wait until they reach rock bottom in order to intervene. And with this particular age group or population, That wouldn't be the clinical recommendation. It's very important that they intervene as they're seeing the concern and sitting down and reviewing constantly and try and prevent that rock bottom from occurring. And, you know, I think it's also very important, and when it's worked a little better, has been when people in the family system or the household are united in one message so that it's not presented in a fragmented way. So say, for example, mom or the aunt goes in with one approach, uncle, father, and grandfather goes in with another, and then people play other family members within that dynamic, that becomes very dysfunctional. So I think having a unified voice, you know, one message is critical in helping an individual come to a realization, well, if they're going to continue to do this, then it's not going to be in this household.
Mm.
Yeah, it's really important too for the family to get help because this affects the
Yeah.
entire family, right? So in a way, the entire family and everybody in it has this disease. They may have it in different ways, and you know, we can call it codependency, and we can call it a lot of different. But there's fundamental actions and behaviors and roles that they take on by living in a house with someone with a substance use disorder. So it really often it's very hard because people have varying perspectives on how they feel it should be addressed and what they want to be done. And you know, kids might be saying, mom, you know, throw them out, and wives might be saying, let's just kind of manage your drinking and only drink on the weekends. And you know, other family members may say, well, it's it's really not affecting anyone because he still has a job, so just let it be. So everyone's going to be coming from these places of what their emotional and perspective is, and out of their own concern, and addressing it is really important. That everybody, psychoeducation, which you talked about, Dr. Anderson, I mean, Dr. Torres, is just so important that everybody in the family get some information and get education on how this affects them and what they can really do to help themselves and in order to help the person with the substance use disorder and what might not be helping. And you talked about setting limits, and it really is about boundaries and limits as well as to what is going to be able to be tolerated within the home for the well-being of everybody in the unit.
And then the elephant in the room is, and say, for example, we're talking about an adolescent. Who else in the household has an addiction? Who else in the household is drinking, doing drugs, and so forth? Because the percentage of the addiction, especially for the adolescent, increases as they get older if there is another person another adult in that household or in the family with an addiction.
Is it most likely that when there is one person with an addiction in the house, another one is going to pick up on that as well? Or is that less common?
That would be a cookie cutter type of approach. I mean, every family is unique. And so just because one person has an addiction doesn't necessarily mean that the other one will, but the risk factor increases. And, you know, as Susan mentioned, then you have the support groups of individuals whose family members, you know, have an addiction, right? The Al-Anon and so forth. So you adjust to certain patterns that will then become part of your reality and personality and future relationships as well.
Mm-hmm. So Aaron, when we're trying to help someone with an addiction, can people with addictions stop what we say cold turkey, or is a pharmaceutical treatment necessary to help them?
That's a really good question. And I think there are scenarios where, while both occur, definitely, it's not recommended to stop using a substance cold turkey. But depending on the substance is the risk, I would say. So, for instance, if someone who is suffering from alcohol use disorder, if they're drinking frequently and all of a sudden they stop, they're putting their body at risk of having a seizure, which could be fatal. So that could lead to death. So in that instance, a treatment of, medication is recommended to prevent that risk of a seizure occurring, usually over a period of 5 to 14 days, depending on how much the person was using. Then in terms of, other substances like an opioid use disorder, for instance, a death related to an opioid withdrawal is not as likely or probable as a death from an alcohol withdrawal. However, opioid withdrawal is very, very uncomfortable. If someone is experiencing high degree of nausea, vomiting, diarrhea, they can have consequences related to dehydration. However, though opioid withdrawal compared to alcohol withdrawal or a benzodiazepine withdrawal, such as a Xanax or an Ativan or a Klonopin, opioid withdrawal carries a much lower risk of death compared to those other substances. So the substances that we see in the hospital most commonly that people are withdrawing from are alcohol, opioids, benzodiazepines, and cocaine or crack cocaine as well. So you can generally think of the withdrawal syndrome as the opposite effect of what the substance generally causes. So alcohol, opioids are more sedating, calming, so their withdrawal effect, you'll have overexcitation, irritability, agitation, things like that. So generally a medication is recommended to reduce the risk of a bad event happening in the withdrawal period. But it is usually can be completed over a short period of time, depending on how much and how long the person has been using.
Thank you, Aaron. Yandira, usually it's not just about the medication. Therapy goes hand in hand with that. So what's the importance of therapy and how does it help together with the medications?
It goes getting back to cognitive development and skills. People need some education, so we usually refer to this as psychoeducation in terms of what does a substance does to our body and how that affects our emotions. So starting with the basics, not only that, but then in terms of stress, how do you handle a stressful or a distressful situation? What are your coping skills? Sometimes things that non-substance users do under stress management conditions, a substance use person haven't even thought about that. I mean, I could, call a friend if I'm having this level of distress, as opposed to going and picking up. So it's doing that. It's providing them the education. It's providing them an opportunity to explore options and to go away from also what I call the past meaning the messages that they got regarding substance use. Whether it's because they didn't believe in a higher power, they don't have enough will, they grew up poor, but to get in terms of what's happening in here and now. And validating, yes, their concerns, but giving them the hope and the tools so that when they do come into a distressful situation, or that they can do certain things, such as a meeting, such as calling a friend, such as going for a swim, running, things like that. So it's a combination of what I usually call the mind, the body, and the spirit.
And Dr. Anderson, what do you think is most important? Therapy, medication, both? And are there people who can recover without medication and just therapy?
I think it's a combination. It depends on the individual. I remember, for example, this 75-year-old gentleman who came to practice, and he was tormented by, having served in the war, and just a military experience and all that. And so what he did in the evening is that he drank and drank to the point where he just fell asleep. And then at about 2 o'clock in the morning, he woke up and he saw Satan with flames right at his footbed, calling him. And at that point, he became suicidal, slashed his wrists. On site in the office, was taken to the ER for the psych eval and things of that nature. For him, a structured environment was critical. Detox was critical. Medication was critical. We have individuals with chronic and persistent mental illness, with auditory and visual hallucinations. And so the combination of using drugs and their mental illness predisposes them to other things. And so that's why it's important for the medical piece and the supportive piece, the behavioral, right? The counseling and the therapy to work hand in hand. And then you have other individuals that have a certain ego strength, have the ability to respond quicker to a cognitive approach and learn how to manage certain triggers that would predispose the individual to the drugs and alcohol. So we would have to assess everyone individually because we need to understand their history. What about if they were, exposed to drugs and alcohol from birth, from early childhood, and now here they're in their 40s or 50s or now 80s taking a pain management medication and it makes them feel good. So it's all individualized.
Mhm. How long does recovery take? I guess it's different for each person. It's different per type of addiction. Sue?
Well, I think recovery is really a lifelong kind of process, right? So unfortunately, they're really, people never recover from addiction unless they stop using the drug. And even if they're not using, if and when they choose to use again, they will resume at the same point and probably go well beyond what the progression was when they had initially stopped using. So it really is, the only terminal illness, right? Chronic terminal illness that we have, that people can recover from, that people can survive if and when they stop using the drug or the alcohol. So, and that's the only way that people are really going to survive. Otherwise, eventually they will succumb to the disease. So I guess when we say recovery is a lifelong, does that mean that people need to be on medications or that people need to be involved in self-help, or does that mean that people need to be involved in therapy for, whatever it might be? It really is just a process of being able to be in the world without that substance and to function, and to be able to have those relationships again in your life and to have your life whole and manageable, right? And medication does help. I mean, I think we have so much, and Erin, this is really like your bag, right? There, it's really an exciting time because people's brain chemistry does shift and it changes when they've used over a period of time pretty much any drug, but certainly drugs like alcohol and opiates, right? And that's any opiate, whether it be heroin or legally prescribed opiates. And our brains can do these remarkable things, right? We can kind of change the neuroplasticity, but we have to have certain medications. And I think it's really exciting as far as medication assisted treatment because it's keeping a lot of people alive a lot longer than they would have if they had never received the type of medications to allow them to have extended periods of recovery and not an abstinence and to reduce cravings and minimize the likelihood that they're going to pick up and use again. So maybe Erin, you can talk about some of that good stuff.
Sure. I mean, we do, the options are expanding as well as the formulations of the medications that are available. So, for alcohol use disorder, we have three medications primarily. The one that's used most commonly and most effectively is naltrexone, which is a tablet that can be transitioned to a long-acting injectable medication called Vivitrol. And so that medicine is very helpful at reducing craving. But what's interesting about this is it also blocks the positive effects or rewarding effects of alcohol. I think a lot of people may go into recovery or complete a detoxification phase, and they're being or they're pushed towards a goal of abstinence, and in a majority of settings a goal of abstinence is what is desired, but even a reduction of use that increases functioning can be seen as a part of recovery. So I think tenets of treating addiction that I've been trained in and I've tried to use in practice are related to harm reduction. So I want to see where the person's at. If you're not ready to completely stop using, let's find ways to do it safer, to keep you alive. And so when you do reach that stage of change where you're interested in changing your behavior, you're alive and you're able to participate in that type of treatment. So the medications, I think, are a great bridge to that period. There's absolutely nothing wrong with someone being on a medication for a substance use disorder for their entire life, as long as they're able to, do the things that they want to do, have relationships, hold a job. However, there are, majority of people I work with, they say, I don't want to be on this forever. So I encourage them to look at the medication as a tool. This is something that is helping to restore your brain health, get you back to functioning so you can participate and really the hard work, doing the psychotherapy, doing the counseling, looking into the trauma. And then once you've developed that network and your social and those coping skills, then considering coming off of the medication is reasonable. We always encourage people to do it at a time where things are stable in their lives, but as we all know, that doesn't always happen. There's always something going on, but at least having the support system and people in place that if you were to run into an issue, you have someone there to kind of guide you back on track.
Mhm. Well, and we could talk about this subject for another hour, I think, or more. But we only have 3 minutes left. So I want to use those 3 minutes for you to let us know where we can go for resources, how we can use your services as well. So please, let's start with Dr. Torres.
Hi, thank you. I also want to say that there is a training that Lehman has also made available to its social work interns and the people in the community called SBIRT. So it's screening, brief intervention, and referral to treatment. So that's something that, just to keep in the back of your minds regarding something that works with our community. I have 14 older adult centers, and it's all about healthy living, reinforcing fitness, wellness, mind, body, and spirit, as Yandira had mentioned earlier, the importance of that. And it reduces the isolation of folks. I also, in the slide, provided you with the SAMHSA's hotline number. That's in English and in Spanish for resources to recovery. And I'm sure that your hospital system has also treatment options as well.
Yeah, we certainly do. We have an inpatient addictions treatment program, and that's the Recovery Center, and that is for the most part a 30-day or up to 30-day of inpatient treatment for all levels of really substance use disorder, including opiate. We treat opiate with Aaron. You're familiar with that as well. We do treat opiate withdrawal. I think we actually can also treat pregnant females, right? We have the ability to treat, and not every pregnant female can be treated with opiate withdrawal, through opiate withdrawal or through pregnancy. And we also have an outpatient program that's 2 to 3 day a week program with off-site, is not here at the hospital, and it's called the Recovery Center for Change. And maybe we can get the phone numbers on. I think phone number to the inpatient is 348-6760. And the outpatient as well you can go online and look us up at montefiornyack.org. But those are the programs that we have, and you know, we do cover pretty much almost all insurances, and do have licensed and certified counselors at those facilities.
Okay, well, thank you so much. We made it right on time. I'm gonna invite you guys again because I would like to discuss also stages of change and recovery and how and relapse and all of that. I think we didn't have just enough time for all the questions that I had. So you're invited again. And to all of our attendees, you're invited again and again and again every Thursday at 12 p.m. We have a very large agenda for October, so please don't miss our community chats. The schedule is on the web at montefiornyack.org with all the links and everything to register. And later on, hopefully today or tomorrow, I'm gonna be sending the recording to all of you to pass along to all your friends. Thank you so much for joining us. Thank you very much to
Thank
all of you for being here and being my panelists. I learned so much as every Thursday, and have a good day. Bye.
Thank you.
Thank you. Thanks for having us.
Thank you, everybody else.